I'm just going to say hello and welcome to everyone. We have 4 excellent speakers, and we also have some questions for you and time for conversation. We're here today to discuss the integration agenda and how that is currently expressed through the lens of creating integrated care systems in places. Patches, maybe we should say. And we've got 4 speakers who can talk about that change and that development from various angles. So I think we're going to have a really interesting panel discussion and then plenty of opportunity for you all to chip in. Before we get going proper, I just also want to say it's kind of fitting that we have an all-women panel on International Women's Day. Let's take a wee moment just to take stock of that. We work in a sector, me and my colleagues who work from National Voices, we work in a sector where there's a lot of women leaders, and there's also obviously now increasing numbers of women leaders, senior women leaders in the formal health and care system. And that's a cause for celebration, we think. But we also, I think, need to be honest with ourselves that we haven't exactly achieved equality for all. Women of colour are very clearly and very strongly underrepresented in leadership positions, both in our sector and in the formal health and care system. And I also think we need to probably be honest with ourselves that women's health experiences are still far too often shaped by sexism or misogyny, or being dismissed as a reliable witness when it comes to describing what actually goes on for us. So it's not like we've done all the work that needs doing, but I think today is also an opportunity to celebrate the fact that we are going to have a really stimulating conversation with very capable women leaders who maybe got to where they are now somewhat against the odds, and maybe they have a moment to reflect on that too. Before we are going on the kind of substantial agenda, I wonder whether anyone wants to briefly say something on the tech. Is that you, Ella, or who's going to do that? Just very briefly, thank you.
Yeah, so apologies, I've got a bit of a sore throat, but you're welcome to introduce yourself in the chat box and ask questions there. We'll make a note of them for later on in the session when we'll be doing a Q&A. There's some arrows here which show you how to use closed captions if they'd be helpful. We ask that you all stay on mute if possible, except for our speakers when they're speaking. And you can change your layout in the top corner so that you can see everyone or just the person speaking. It's up to you. And that's it on tech.
Super, thanks, Ella. If you have difficulty, you can reach out to the National Voices team here on the chat. And if that is a problem, you can email us at info@nationalvoices.org.uk and we will try to help you overcome our issues. Ella, have we got automatic captions turned on?
Yeah, I'm pretty sure I turned those on.
Okay, cool. So if you rely on reading the spoken word, hopefully that's popping up for you. I can't see that because I'm on a very small stamp here. Okay, this is the agenda we're going to work through. It is maybe no surprise that we at National Voices have an interest in keeping the integration agenda wide open. It clearly offers an opportunity for everybody with a stake in health and well-being to get around the table and to improve the health outcomes and well-being outcomes for people living in a patch. But we think there's also a risk that it's then interpreted by NHS colleagues as being about NHS organisations talking to each other and integrating with each other. And that maybe then an unintended consequence of the ICS agenda could be that organisations that aren't part of the NHS family, or maybe social care, you know, on licence, that all of us who aren't part of this formal health and care landscape end up getting pushed out and have less access to decision-making spaces, which would obviously be regrettable and would probably have negative impacts for people. So that's the sort of problem we're trying to crunch today, and we try to keep it quite practical and to understand what can be done to prevent that from happening, and where do we see the levers to make a change there and exert some influence. The people on the call, the people who are joining this meeting are a lot of charity colleagues, a lot of colleagues from the VCSE sector, but also people from the NHS, from academia, from think tanks, from professional bodies, and welcome to all of you. We tend to convene a really interesting group of people. Oh, and I shouldn't forget normal people, you know, people with lived experience of using health and care services often join our events too. It's an interesting bunch of people, and that's often why we have really interesting conversations. So we try to keep some space for that on the agenda. So I will hand to Sarah, Dr. Sarah Wollaston first, who was the chair of the Health and Social Care Select Committee in the House of Commons for many years and led that committee and its inquiries, you know, with deep insight and expertise, because she's also a jobbing GP, and with heart. I always felt like it wasn't all about point scoring. It was about getting to the nub of the issues, and often the nub of the issue in health and care is sort of slightly beyond party politics. Interestingly, it's more about, do you actually know something about health and care or do you not? So she's had an interesting background, therefore, obviously, in understanding the integration agenda inside out, and it's now the chair designate for the system in Devon. And it'd be interesting just to hear your reflections, Sarah, on how has that journey been, and what conversations do you have with other chairs, and how do you try to keep the system in Devon open to enter partnerships and keep in conversation with organisations and communities who aren't necessarily part of the NHS family? Over to you, Sarah.
Well, first of all, thank you so much for having me. It's wonderful to be here on International Women's Day. And just to reflect on your past point, yes, my background was first and foremost in the NHS. I joined the NHS in 1986 and really enjoyed that, and being a GP trainer and an examiner, and also an examiner for the forensic medical examiner, working with Devon and Cornwall Police, seeing mostly women, some men and some children who'd been victims of sexual violence. Then moving into a career in Parliament. But during that time, I very much wanted to take a cross-party approach to what I did, and went down the scrutiny route. And select committees are not part of government. They're part of the structures of Parliament that hold government to account. And so now, after I left Parliament, the pandemic struck. So I went back into frontline clinical practice, which was wonderful to reconnect with that. But now I'm chairing the integrated care system for Devon. So I've been asked to do a little reflection on the background to the legislation. So at heart, its purpose was to sweep away some of the very restrictive rules that got in the way of people integrating, because we've all been talking about integrating not only vertically within the NHS, but also across all the different systems. And it feels very often as if the system has to work against the rules, in spite of the rules. So the primary purpose was to sweep some of those away, to be essentially permissive and make integration easier. I also know, and certainly my background as an MP, is that what people really want is to see the voluntary sector and community enterprise delivering more services. And there's always been a real frustration about the lost opportunities in reaching out to all our community assets, and also using the power of the NHS and the NHS pound as an anchor institution to go further and to reach out. So very much support what you're saying, Charlotte. It would be such a wasted opportunity if all this legislation does is produce organisational churn and people talking just about systems, rather than saying, how are we making a difference to the individuals who rely on services? And how are we doing that in a holistic way that matters to them? So I think if we get to the end of this process and there's no change for people who use services, no reflection of the opportunities to tackle health inequalities, go further than we have done on the issues of equality, diversity and inclusion. You know, there's real challenges there, and you know, the recent reports that look at the way that service users as well as staff have been very severely discriminated against. You know, we need to make progress on those issues. And also there are the challenges of net zero and climate change. We must try and look beyond the immediate and look over the horizon. Now, with any legislation, what you find is that all sorts of other things get added on, what we call a Christmas tree bill. So we end up with things added to the legislation that weren't part of its original purpose. So, for example, we're seeing quite sweeping powers introduced, of powers of direction from the Secretary of State. So there's lots of challenges ahead about whether we see a series of top-down initiatives that undermine the core purpose of what local systems want to do. Because at heart we have a broader system of partnerships working alongside the NHS organisations that will take over from CCGs, and we need to explain what they're about. We need to make sure there are opportunities for everyone to come together to genuinely input, particularly into the partnerships. So I'm very hopeful that there are lots of opportunities here, but you know, we do face very significant challenges. We face, particularly in Devon, an extraordinary financial challenge where we have our underlying financial position is that we're more than 300 million in debt. So how do we try and create the space to do the things we want to do, to actually shift funding out to local areas, to invest in voluntary sector and community enterprise partners, and as I say, use what we can to support other ways of working. How do we do that alongside the huge challenge of elective recovery, of extraordinary increase in need, huge inequalities, you know, across the system, and driving real integration in all its opportunities of everybody working together, but keeping our focus on the patients, because we mustn't in all this, and I say patients, I mean service users, sorry, across the wider system, keep our focus on the people who depend on us the most. But I'm going to stop talking now. I think I'll overrun my time. Thank you.
Thank you so much, Sarah. Interesting journey you described, both from Westminster to Devon, but also from original legislative intent to, you know, a bill and the politics that then ensues. And I really hope we have time later on to unpack a bit more what the challenges are and how you are beginning to tackle them. We used to, in a previous role, I used to do some work in Somerset, and I'm just aware that they share, you know, the age profiles, and that is just, you know, a very steep challenge for all of you. But yeah, we have time to unpack that. Before I come to Kaneez Shaid, who will talk about her work at Rethink, but maybe also other really interesting work she's involved with around democracy and user voice and citizen voice. I need to skip back one step because I forgot in the introduction to make you all answer 2 questions for us. So there's a hyperlink in the chat that you can go on, and we basically ask you where you're from, what kind of an organization do you represent here today, or who do you work for if you work for anyone? And then the second question is, do you feel like you have a way of influencing the ICS agenda locally or nationally? So are you engaged, essentially? So if you, in your own time, try to find that link and then answer that question, that'd be wonderful. And then after our speakers have spoken, we will see the results and can see who's in the room and whether people feel engaged or not. So I hope you're all great at multitasking. One thing we've learned in the last few months is do one thing and look like we're doing another. And I'll hand over to Kaneez, who will talk to us about her perspective from the sort of civil society angle. How do you engage with formal services and structures of the state to bend them towards the need of communities? Kaneez, I'm really interested to hear what you've got to say.
Thanks, Charlotte. Thank you. So it's interesting. I've never worked in the health sector until I came to Rethink about a year ago. Before that, I was chair and leader of an organisation called Citizens UK. And the methodology was simple. You get down in the ground, in the grassroots, you do the listening, you surface all the issues, and then you bring to the table people of power. And then it's not like an activist methodology, it's more like locking into negotiation and compromise and making some deals, but some very, very long-term accountability attached to it, which stretches this timeline to years. And the work we did in my previous role was not really about the change, it was about developing leaders, and that's what we focused on. You get the leaders, you get their ideas forward, they front on the campaigns and the work, we leave something behind which is sustainable but extremely grounded in solution-based things. And so that's what I did for about 20 years. And then I recently joined Rethink, and that's what I'm really here to talk to you about. So I'm just gonna, Charlotte, I'm just gonna start my 5-minute timer, in case I run over, do stop me. So thanks very much for calling me here, everyone. At Rethink Mental Illness, I'm head of community engagement. And I'm just going to say we're not perfect. We are learning all the time in our work, but we are now hovering across a number of ICSs and doing some work. And just to give you a little bit of framework on Rethink Mental Illness, it's a charity for people affected severely with mental illness. So that is schizophrenia, that is bipolar personality disorders. But we also run a lot of the services. We have about 3 million people ringing our help lines every year, but we have about 15,000 people in our QC run services, prisons, crisis houses. So we were taking some of that experience and now helping to set up the ICSs. And we've learned loads from the COVID experience as well, that really disrupted traditional rules and structures and behaviors. And that led to lots of new conversations, lots of new relationships, and lots of new trust being formed in those spaces. A lot of innovation sparked through that. And we took some of that learning into the ICS work we've started to do. So we're working with the integrated care systems. We're building place-based alliances. We've created a unit called the Community Mental Health Unit, and it is trying to create these ICSs, bring the voluntary sector in with the NHS and the local authority to create better systems for people suffering from mental illness. So that's what we're doing. We are all over the place. We're in North East Lincolnshire, Tower Hamlets, Coventry, Warwickshire, Sheffield, Cheshire, and we're all on the ICSs part of the work. We've only got a few moments, so I'm going to talk to you about Somerset, because that's one of the models that's been in place for about 3 years, whereas the others are in different stages, some are new. In Somerset, we've created what we've called Open Mental Health. It feels like a bit of a movement. It's about 10 charities that have come together, and Rethink is the lead accountable body. So there's different ways you can set these structures up. So we tend to go for the lead accountable body, but in other places we're running workshops, for example, in Essex. Some of the lessons we learn are that one, leadership really matters, and some of this will seem like it's an old broken record, but really leadership is at the heart of the work. Culture change, having buy-in all the way through the process, doing the work with a lot of integrity is really important. But the stuff I want to pull out from Somerset is around language. So we've started to move away from certain words, and they really matter when you're integrating with the community. So we've stopped using words like referral and threshold and triage and signposting and discharge and closing off people from the system. So the system we've created in Somerset is really open. It's open mental health, but we are using alternative language and i.e. alternative ways of working, and we're engaging people in the community in different ways. I can give some examples later on, but that's one thing I want to bring out. The second one is around principles, values, and ways of working. We hear about this so much, it's so overdone, but we have to start with how we're going to work together. And so that is about collective strength. It's about bringing users in as equal partners. It's about being value-led all the way through it and being equal partners. What does that actually mean? So we really crack open that conversation right at the beginning of trying to bring these different sort of parts together in the system. If you don't spend time on values and the way you're going to work together, all kinds of strange behaviours begin to appear. And I think it just saves a lot of headache if you have that up front written down. This is what we sign up to. Yes, we're in agreement of that. It takes a long time to get to there, but it's worth it. We also have something called guiding principles in Somerset. One of those is having open access, i.e. no wrong door or no door at all. So we've brought out these values and these principles right at the beginning of these conversations. That's helped a lot. Another thing we've learned is around how you engage with communities. And it's really important we pay attention to small players. Money and funding doesn't just go to the traditional, typical major players. So as we've done that work, and COVID's taught us that BAME communities are particularly suffering from lack of funding. We've gone out into the communities, we're realizing mosques and churches and some of these amazing institutions, even football clubs, are already doing mental health work, but they just don't have that strapped on the top of their institution yards. So that's really important for our work. Bring in unusual people. We are in the business of, oops, it's my 5 minutes up. Didn't even get started, Charlotte. But just before I hand over, I've got just 2 more minutes to extend on that one. I think the other things I'll add is trust, relationships. There are no shortcuts. You have to take the energy and do that. It's about ongoing development. It's not one-off. It's going to go on and on like a cycle. You've got to develop spaces for reflection and growth, and you've got to do it together. I think money is absolutely critical. We could spend a whole day talking about money, the way it travels, the way it corrupts, the way you set those systems up. It really defines the relationships, governance, the principle of co-production, bringing in experts by experience that sit on the boards, that sit on the work streams, that really have a proper voice. We're using all kinds of co-production tools like rounds, you know, that really balances the power of the room out, makes everybody feel comfortable and equals that space out. And then coming all the way back to grassroots, bottom-up organising is essential. The solutions and the answers lie in the communities, actually. And work streams come down from NHS, but these other solution-based conversations go up. There's a conflict in the middle, and that's why co-production is important to kind of bring everybody off. Comes back to values again. But I'll stop there, Charlotte.
Super interesting. Thank you, Kaneez. And I think I can see the connection to your previous role in Citizens UK very clearly, that commitment to trusting communities that they will own the solutions and not just the problems. I think that's a very powerful thought to hang on to. And I've just seen in the chat, we've got colleagues joining us here from Dementia UK and Alzheimer's UK and from Compassion and Dying, and Tracey obviously is from the end of life sector, and mental health service and experts by experience. And I think there's a lot there that could be learned from the work you're doing in all these areas. HIV, I've just seen pop up. No wrong door, you know, not endless assessments and endless referrals. Actually, wherever you wash up, we will tend to your needs and aspirations. I think those are very powerful design principles, and we haven't really tried to unleash those in the wider system. So let's try to explore that a bit more in the conversation. I'm going to hand over to Hannah now. Hannah Gagan is here today from one of our partners, Coloplast, who are a medtech company, and they produce tech and products in the sort of intermittent urinary space. And they are working obviously very much in partnership with the NHS to get this to people and to work in partnership with people to understand what makes for a good life. So Hannah, you've also worked, I think, in the BCSE before, which is probably why you're a friend of National Voices. Yeah. But yeah, could you just talk us through what do you think is required for this to work, for the NHS to stay outward focused, but also maybe for industry players to play their role in these partnerships? Over to you.
Thank you. My name is Hannah Gagan. I'm Head of Government Affairs and Patient Advocacy for Coloplast. In terms of audio description, if needed, I'm a white woman in her 30s, a terrible 80s perm, but I'm rocking it, I hope. And it's definitely bleached blonde with a hint of purple, and I'm wearing a navy blue top. So in terms of before I came to Coloplast, it was all really quite serendipitous, really. So I myself have a stoma. So I got that through having ulcerative colitis, and I was definitely a patient of the NHS for a long time, having lived in hospital for at least a year with multiple surgeries and kind of in and out. So I come from that personal perspective of having a long-term condition with a very intimate healthcare need. So I spend most of my time at work talking about wee and poo and bums and stuff, like it's just what happens. So that's what I do. And no, you know, it's intimate, so people worry about talking about things, but it's just stuff you have to talk about in order to get the care that you need, I suppose. Before Coloplast, I'd worked in pharmaceutical companies. I used to work at Marie Curie Cancer Care, so end-of-life care, and I was also a trustee for a stoma charity, and before that worked in the cultural sector. So I saw that there was a kind of an arts and health, I think it was Alexandra Coulter I saw on there, sort of an arts and health brief, so I understand that bit as well. In terms of, first of all, thanks for having me, of course, and again, happy International Women's Day to all the women on the panel and in the room. So really briefly, to put it into context, I suppose I should say a bit about Coloplast. So we're a Danish company, but our head office in the UK is in Peterborough. We do basically leading in making products in terms of stoma products, continence products, and urology products. And basically, we also have services alongside the products that make life kind of easier for people living with deeply personal and private medical conditions, often associated with trauma and taboo. So we basically believe that in order for, you know, in terms of your question around integration and partnership, we work kind of hand in hand with the NHS in different parts of the UK. And we're a vital partner to them. And there's two projects that I was going to briefly talk about today to kind of talk you through those examples to answer your question. So the first one I was going to talk about is actually on Tracey's patch, which is in King's Lynn, which is a project in the stoma service there. And that was basically, let me just get out the bit. So yeah, so in terms of that, is they needed to improve the stoma service. So this was both in terms of not just the physical stuff you get when you've got a stoma that you need the help with from a nurse, but also, again, the mental health support that you need and the social support. So again, Kaneez, some of the stuff you were talking about, it definitely relates on this. They needed increased stoma nurse capacity. So what we do is we work both in hospitals with the NHS and then also in the community sector as well. So people from when they have their stoma cited, surgery, and then as they come out into the community, a very kind of self-care model. So as well as, like I said, kind of creating, manufacturing the products, we also deliver products to people's doors. So they can order it online, and it's all kind of like as smooth as possible for a person with an intimate healthcare condition to get what they need, as well as we're also CQC outstanding rated. So we've got a telehealth line, so people in the service can kind of have that integration between in kind of when they leave hospital back into community and then onwards. In terms of the Queen Elizabeth project, we've actually just been announced as a finalist in the HSJ Partnership Awards. So fingers crossed, we will find out in March whether we get that. But in terms of the achievements, I suppose some of the stuff that I just wanted to talk about. So it happened both for patients and for the trust, but also for the stoma nurses themselves. So in terms of monetary value, I've got down here, we made the value-add interventions made savings of 119,000 to the trust. In terms of prevention, a total of 819 avoidable appointments with consultants, GPs and clinical nurse specialists, which then freed up additional capacity, a 95.83% approval rating from patients. And then also we then continue to deliver the service in the community as well. In terms of Sefton, which was the other one I wanted to talk to you about, that again, I was kind of bowled over when I heard about some of the stuff that they'd been doing up there. But essentially, in terms of achievements, again, of what the NHS and Coloplast has done working together, £154.24 person saving on stoma product spend, despite increasing the number of patients receiving stoma products. That was in 1 year. We established fast-track clinics to ensure over half of all patients received a review in the first 3 weeks of the project's launch. And it was a 17% improvement in the rate of patients describing the service as good or excellent. So they were kind of like the achievements, a bit about the kind of projects that you get. And then I suppose in terms of that specific question you ask around what we could do in terms of the learnings, I think my reflection is definitely from the patient's perspective as well as the Coloplast perspective. I think it's that it's such a specialist. I think maybe people think that you just get a bag and you stick it on a tummy and you crack on in stoma, and then you've got a good pathway for a patient and then a pathway that's kind of less desirable in that sense. And I think the things that we're able to do in partnership is with our nurses, working with NHS nurses and with the services and the product, is understand a patient like me. I can be like, right, I'll tell you what I need, what my lifestyle's like, and I need you in terms of shared decision making, clinical decision making, to tell me what I need that will be appropriate for me to be able to live my life to the fullest. And I think that that's what I think our partnerships have been able to do really well. I mean, in terms of data, which I know in terms of the long-term plan, we've been able to help in terms of data as well, and in terms of kind of like digital management. And in terms of the health and care bill moving forward and the ICSs specifically, you know, we are really keen that it continues to focus on community care and patient safety, of course, patient voice, as you would national voice, you'd expect people to say that, but I think there's also a pitfall potentially in having just one patient voice per region in that sense. Like we talk about, it's like N=1, like how I feel about my service and my condition will be very different from how somebody else does. So ensuring some kind of mechanism where a range of voices can be heard in that service delivery, I think is really important. And then again, I suppose I would just a big shout out for all the NHS stoma nurses out there, you know, making sure that they continue to be supported in terms of discharge and also community and acute. But I mean, there's more I can say, but I think that's it.
You'll see for later, because we're going to have time.
Yeah, that's my timer.
Super. Thank you, Hannah. What an interesting perspective. And I meet you today for the first time, so I wasn't aware that you're also talking from a lived experience perspective. So thank you for sharing that with us. Right, finally, last but not least, as they say, Tracey, you and I go back quite a long way. Tracey used to lead Hospices UK until very recently, and is now the ICS CEO for Norfolk and something. That's fine. Sort of at the moment shadowing, but obviously it's already moving and shaking, because it does take that, doesn't it? So yeah, another interesting journey you can describe for us today. Maybe there is a theme here that we need people who are used to crossing boundaries to make it work. Tracey, over to you. Just your reflections, please.
Thank you, Charlotte, and hello everybody. It's a real pleasure to be here and be amongst colleagues from the voluntary sector again. My name's Tracey Bleakley. I started my career as an engineer, actually, which is when I really started thinking about systems thinking. And when I was doing my degree, I also worked for British Rail through privatisation. So it really gave me that really good sense of shifting and changing and going through a massive culture shift. I graduated and then spent 12 years as a management consultant, working around the world, doing lots of mergers, demergers, acquisitions, HR, finance, culture shift. One of the big ones was working with ITV through the merger of the television companies. So going very much from local to a national organisation and all the changes that that brought. And then I did my MBA and I had a bit of a Groundhog Day and wanted to do something different. So moved into the third sector. Spent 12 years working for charities. So that was working in overweight and obesity, public health, working with children and families, education, policing, and then the last 6 years with Hospice UK. So I've been 2 months now with the NHS. I still look at my lanyard and just jump, think, what's that doing in my handbag? Never quite imagined that I'd end up working for the NHS, but it's really good to have a fluid, exciting career, I think. So I've come in at an interesting time. My organisation, who is paying my salary, is still a clinical commissioning group. My team are still in their CCG roles. We still have a CCG governing body, and that will be in place until the 1st of July. On the 1st of July, I will shift into being the chief exec of the Integrated Care Board, but as yes, it doesn't exist. I'm going through the process of moving my staff into new roles, so changing the way we operate, and I'm hiring new people, but we still don't have the legislation passed. So it's all a sort of a bit I wouldn't call it shadow, because we're still dealing with sorting out our budget, and like Sarah, massive deficit. We have 250 million, but we are going to break even one way or another. We have been dealing with winter pressures and being a critical incident across the system, which we've now stepped down from. We're trying to sort out where our places are, which I'll come to in a second. And we are trying to figure out how we do things completely differently now we're coming out of COVID. So we have issues across the NHS in terms of what we call elective recovery, which basically means people are waiting for over 2 years for operations. We have people in hospital who can't get out but shouldn't be there. And we have more than 400 people across 3 hospitals. That's a hospital worth of people that don't need to be in hospital, don't want to be in hospital, and there's nowhere else for them to go. So we also have issues like everybody else around social care and capacity. We have issues around accessing GPs and primary care. And what we want to do is turn that on its head and think about well-being. I love copying really good ideas. So I want to totally copy the Wigan deal and have a big audacious goal for our community. I keep hearing from people that we've got these 10-point strategies that everybody in the Norfolk and Waveney knows, almost as though they're there on the kitchen top and everybody refers to them every morning. Can't imagine that's true. So I think if we do something like saying, we want for Norfolk and Waveney another 5 years of healthy life expectancy, that everyone could remember. We could think about how we're doing that across health, across social care. Employers could think about it in terms of well-being. Talk about it in schools, families could think about it. So actually that's something that I think we could all coalesce together. In terms of the integrated care board and integrated care system, I see that it's got 4 strands and they're equal. So one's the NHS, one is social care and local authority provision, one's the voluntary sector, and the 4th one is residents. And it sounds like a minor thing, but I've actually scrapped our new logo and asked for it to reflect those 4 things so that we think about that from day one. And what I'm noticing coming in is that we've got all these shiny new strategies. I think the NHS and the local authorities are working well together because we have to, because we've got too many people in hospital. And because we've got quite an ageing community here, people are really mindful about social care. But I never see the voluntary sector in there, and I certainly don't see residents. I don't see talk about carers who are often invisible, and families. So I keep pushing back on that at the moment. I talked about place a little bit because integrated care systems are so big. We've got to get away from this command and control. So I'm accountable for £1.6 billion a year of spend. I have to make it break even, but I'm going to devolve as much as that as I can to local decision making, which is a little bit scary for me and my organisation, but we will trust local people. So we've created 5 places in Norfolk and Waveney, and we're putting place leaders in there. And I'm trying to get them not employed by the NHS, but I don't know if I'm allowed to do that. White papers are coming out left, right and centre. And those people will be making decisions, working with the voluntary sector, working with local community groups, working with residents, deciding on how we do things differently. And they will have the budget and they will have the autonomy. But the flip side of that is they'll have the responsibility to share good practice, share learning, be very transparent about what's going wrong as well. And we've created a voluntary sector assembly across the whole piece, and then we're creating these place levels. So we're trying to find ways of giving people a voice. Something else that I've noticed working for both sides is that I think the NHS needs to bend a lot more towards the third sector. We talk about our bureaucracy as though it's necessary because we're handling public funds. It is, but it is also patronising to suggest charities don't do that, because what are donations at the end of the day? And I think we need to look and see what we need to do, what is useful information for the charity and what's overkill. But equally, charities need to accept that when we do ask for a minimum amount of data, that is because we need it, because we're accountable to the NHS and we're accountable to government. And ultimately, I see my bosses as being the residents of Norfolk and Waveney, but the NHS structure is there to be able to hold me to account to some key performance metrics, basically, so I do a good job. So I'm here for the public, and then the public will work through voluntary sector and we'll have NHS and social care, but they all link. And I'll just make a final point. There's probably lots of things I can add through the chat, but we talk about communication, and I've noticed coming into the NHS, we have meetings all day. Everyone has meetings all day, 10 hours a day. and that's just within the NHS. So how on earth are we going to get out and talk to all of you? So I'm basically taking a mallet to so many different cultural things at the moment. We're going to smash down these meetings for the sake of meetings and use program management offices much more efficiently to track progress, and use Microsoft Teams and send an email, don't ask for a half-hour meeting, and all of those things to make sure our communication is much more efficient and not just presenteeism, and then actually physically get out and go and meet charities. And I think it's really important to walk the talk. So one of my earliest meetings was with Active Norfolk. They still couldn't believe I did that, but that was really critical to us, I think, in terms of thinking about health and wellbeing and that agenda and getting everybody on board. I think it's utterly critical that the ICSs are completely different from the CCGs. That's what we're trying to do. We know we've got a difficult job in terms of the money and in terms of where we are now as a system, but it can't stop us. And I'm incredibly lucky, I think, in Norfolk and Waveney. Part of the reason I joined, we are in a difficult situation because we've got nowhere else to go. We're in the worst level of performance of the system, which is great because it means we have to innovate. But there are some utterly terrific people here. So I'm very privileged to be a part of it.
Wow. Yeah. I mean, I was aware that it's a challenged health economy. I wasn't aware it's the lowest performing one. Well, however, whichever way you measure that, because I'm sure there's a whole lot of very good performance going on, not least what we've just heard from Hannah about some good innovations. Wow, that was a really interesting kind of canvas you've just painted there for us. Loads of shared themes, I think, around shared vision and the need for investing in relationships and the role of the VCSE, and something about describing what you want in language that makes sense for people. So I think language has featured quite a lot. Let's try to continue the conversation in plain English. And before I open it up for a round of questions and thoughts, I just thought Ella could maybe tell us who we've got in the room based on the Mentimeter results, and also how engaged they feel with the agenda. So the vast majority of people here who voted anyway, I mean, this doesn't quite count 110, but never mind, are national charities. Now, I think often people assume national charities are large charities. And I think that is a misconception I want to disabuse you of. There are obviously some very large national charities, but there's also a lot of smaller ones, and even some that look after really big conditions or very shared problematics are often not massive, whereas some local charities can be quite sizable. So I think we mustn't conflate the two. We've got a couple of inclusion-focused charities. I'm hoping inclusion features also in the work of other charities, but maybe these are two that are very explicitly and solely focused on that. And some local charities, which is always wonderful to see. One of the reasons we keep our engagement online is that we can reach organizations who would otherwise not be able to join us. Yeah, 12 people at a national charity. Yes, so are we, 11, I think. And then we've got some system partners. That's what we call you. You are NHS colleagues and people in charge of formal services. Welcome. Some lived experience partners, which is also wonderful, and some other, I don't know, we can unpack that at a later stage. Maybe you are working for higher education institutions or think tanks or whatever. Right, and then the second question we asked you was, how engaged do you feel with the ICS agenda? And I think, you know, unsurprisingly, we see that the national charities are quite well represented on all of the bars, because obviously you're the highest number. So most people here feel a little bit engaged or able to influence the agenda a little bit. And then slightly more people feel that they have great influence rather than no influence. But maybe system partners are slightly overrepresented there. I mean, we're obviously talking about small samples, but it wouldn't be entirely surprising if you work inside NHS England, if you have more of an opportunity to influence the ICS agenda than if you run a carers charity in Norfolk, let's say. Although I would have thought working with Tracey would open some opportunities. And we've got some lived experience partners who are happy with how they feel they're influencing things, which is great to see. Right, Ella, if you take that down so we can see people's faces again. I don't know whether any of the people on the panel have any thoughts looking at that data, or whether you want to move on to other questions, just very briefly. Anything you want to add to the data we've just? No, okay. Where did you, when you listened to each other, what were the kind of common themes you heard, or maybe reversely, what stuck in your mind as in, oh, I hadn't thought of that? I just pass that question maybe back to all of you and just invite you to reflect a little bit on what you've heard. Sarah, you again, what went through your head as you listened to our colleagues here today?
But the enthusiasm of the possibilities of what we could achieve here, and how actually getting those ideas from communities, the bottom-up solutions. I've seen that so often myself over the years. And one of the things, of course, that COVID did is it just showed us that we could be flexible and nimble, and we could engage. I mean, certainly in Devon, the success we've had with our vaccination programme, really quite extraordinary success, has been absolutely because we worked with the VCSE partners to actually reach out, particularly into communities which were at risk of not taking up the vaccine. So how we could be nimble and develop our outreach. But that doesn't happen unless you listen to service users, and you have to do that. So that's very, very clearly came across. And also, just like Norfolk, we've set up a VCSE assembly, and we really do intend to, as we go forward, make sure that we use the opportunities and through Health Watch and other partners to actually make sure that that we start from the bottom, that we reverse the telescope, and we're not just talking to ourselves in the NHS.
And when you, I suppose there is an emerging community of chairs in this sort of world. Do you have a sense that your colleagues share this commitment, or do you think that they're on different ends of the spectrum or on a journey? What's your feeling? Where does this feature in people's universe?
I think this absolutely is a common thread in all the discussions, and a real determination to tackle health inequalities. We have, as an ICS, or we're going to call ourselves One Devon, to look at the partnership side of it, and NHS Devon for this successor body to the CCG, because we're trying to move away from these dreadful three-letter acronyms. The acronym spaghetti in the NHS, nobody understands. So we wanted to have terms that did what they said on the tin. But I think, like other systems, you know, we do want to involve people. So we're having, as I want, looking at our non-exec directors, we're having people with a special remit for health inequalities, another NED with a special remit for citizen involvement, and looking at inclusion and diversity and equality. These issues matter to us, and actually making sure that our board reflects the balance of our communities as well. But you know, really having that very strong link in with the VCSE, I think if we don't have that, we'll be wasting the opportunities that come.
Kaneez, when you were listening to your colleagues here today, did anything jump out at you as controversial or new, or did you see a lot of shared agenda emerging?
Yes, I think communities that are organised with a plan is one way to take the power and make sure that change actually happens. If we leave it just to our statutory partners, NHS and local authority, even though they are trying to reach out, it's difficult. But communities coming together at a local place with a plan, we know that works. When they get together, when they are bottom up, and the problem is, Charlotte, that we're working in our small charities don't have the time to get out and actually get together and figure out their self-interest and figure out if they can get into common interests with others and come up with the plan. And, you know, that's not something that naturally happens. Somebody has to step into that space and help and put that, you know, focus in. And then people kind of start to build the relationship and the trust. It kind of needs that to happen, an enabler. But if you just leave it to the communities to organise themselves, there's no glue that pulls that together. But we know for certain communities that do collectively come together at grassroots, that do have a plan, that do share their stories, they then it will follow with solutions. It will follow with really common sense asks. And then when they do have that conversation with people in power, the people in power actually want that. And so it makes sense. They kind of connect with that and go, of course, we want to change the system in that way. So the question is, you know, what is the change we want to make? Who is going to step into that space and make that change? And what does it look like? What we're really trying to do, if we break down the word transformational to change, we are trying to change people, power, and money. If we can get different people in the room having, that will spark different types of conversation. It requires shifting power to have that brave space and that brave conversation. But when that does happen, the outcome is money begins to change. It's not the same money going to the same places doing the same stuff, but actually we might see physical things appearing, that shifting is really powerful. And I think you said something earlier about pushing decision making out and decision making into another space. We are sort of forcing that in this methodology at Rethink. So I used different methodology in my previous role. This one, we're putting experts by experience, that we're reaching out in the community that reflect the local spaces, and we are actually forcing almost to put them onto the boards, onto the work streams. And there's so many examples of good practice I can give you that we're already seeing. Like, for example, in Coventry and Warwickshire, where we're working, one of the first board meetings I went to with the trust, we had an E/E in the room, but the agenda was quite dominated by the NHS. And I asked a question. It was my first meeting, and I said, is it possible to put an E/E in as a co-chair? You know, can we share the chairing of this space? Well, you know, it's a long story, but about 5 meetings on, that co-chair became, you know, she was shaping the agenda. Not only was she speaking at the table, she began to shape the agenda. It's really changed a lot of things. And now we're seeing some of their work streams are getting co-chaired. So that can happen. We can put leaders into roles and actually trick the system up a little bit. We are disrupting spaces. Co-production doesn't mean all get nice and press blend on the go. There's a lot of hot, you know, anger. We're cooling the anger down. We're having dialogue in that space. It's very complicated work, but I think organizations
it addresses injustice in many ways, and trauma of services having let people down, and structures of the state having hurt people and let them down. So I think we're kidding ourselves if we think this is going to feel like Sunday school, isn't it? It's going to be there's going to be conflict when we let communities set the agenda. When you say you believe that you need a community with a plan, and that it's not about outreach so much as in-reach in a way, I always worry that there is a sort of unholy place where the left agenda, you know, the agenda that says communities have the answers, and the right agenda, which says the state is not the answer, coalesce in a place where it's like, leave communities to it. They can sort it out. And I just, you know, for the record, think it might be worth if you just, you know, say, because you also mentioned communities often aren't supported by strong organizations, small organizations that look after marginalized people, haven't got the power to get into the decision-making rooms, they haven't got the resource. What kind of money transfer happened to get this off the ground? So the Somerset Health System was enlightened enough to give how much money to your alliance of mental health charities? Do you know, or is that
it went from £1 million to about £4 million contracts now going to the voluntary sector.
Okay.
But that was alliance building. So the way we've cracked it through the ICS work is we're building alliances. So we are rethinking in that space of bringing voluntary organizations together, but they're then signing up to letters of understanding, memorandums. So there is some kind of very loose governance, not too tight, but a loose sort of understanding. And that enables money to then just filter down into the community. We also introduced mini grants, so quick £15,000 mini grants that voluntary organisations could apply for. Take the bureaucracy out.
Yeah, I think that's a shared theme a lot, is that you need to get small amounts of money out without too much bureaucracy, without demanding people promise God knows what, and just say, you're a good thing, we want you in the space, we need to hear from you, have a little bit of money.
Charlotte,
Sorry,
Charlotte, just to say, there was something really interesting what you just said. I just want to underscore it, and that is people's recoveries built into stepping into those leadership roles.
yeah.
So charity sectors that are doing the work, people that are using their services, when they get engaged and are allowed and given permission or actually move into that space themselves, their recovery is built into that. So they rise in their leadership skills themselves, but that's sustainable. You know, when you rise in your skills or your relationships, that doesn't go backwards. That can only be a better thing that you're leaving in those spaces.
Right, I just want to give Hannah and Tracey also a chance to reflect on the panel discussion, but I also want to invite all of you here today to put your questions in the chat, and the National Voices team are monitoring that and then telling me what questions are coming up. I've picked up on some stuff around confusion around place and system and where decisions being made, and I know that that's very much a shared concern across a wide range of pathways, and that is sort of almost exacerbated around some of the specialist commissioning pathways, where I think people feel very uninformed still and quite out of the loop as to how that will work in practice. And if by definition almost specialized commissioning looks after rarer conditions, and therefore the charities and the VCSE organizations in that space aren't very rich and powerful often, and how can they influence specialized commissioning in 42 places? This is a complicated question I think we still need to unpack. So I've picked that one up, but there might well be other questions. So please put your questions in the chat and the team will tell us about them. Hannah, what reflection do you have after listening to the colleagues on the panel?
I noted down a few things on my scribbling away. So I suppose the first one that I noted listening to everybody was about this partnership bit. So I suppose the bit that I didn't talk about that I think is really important and how this has worked really well for us is we don't just work with clinicians and stoma nurses, but we're also obviously with the industry partner, but we also work really closely with the third sector. So specifically in stoma with Ileostomy Association, Urostomy Association and Colostomy UK. And a piece of work we've done really recently is on a bit of research. So it's been a Delphi method study. We've worked on research which is about to be published. And on the back of that, we can then go forward and kind of also campaign together in terms of raising the care of, stoma services. So it's this thing about us knowing how to do the techie bit of making things, listening to patients, represented directly through those patient groups from the ground up, as we were saying, from that grassroots, to have this perfect combination of the right product for the right person. And then also the right pathway as well. So I think that's what we've seen with Sefton. I was just going through my notes and I saw that one chap hadn't been seen for 53 years until in the clinical service, until the service came together between us and Sefton. And I think that joint insight was really important. I think the other thing that we haven't spoken about as much as going back to the ICS piece and working together in partnership is, I think sometimes when you hear the word industry, I think the impression is people can be quite skeptical about how it can work and things. And I think, again, in the example we were working in King's Lynn, as one of the nurses, I think potentially was quite skeptical. And now she's just like, oh my God, I don't know how I did it before, working with the nurses in partnership and, in terms of just getting stuff off her workload and everything like that.
Let me just interrupt you there, because I think those are really interesting points, but I just also want to give Tracey an opportunity to reflect on what we've heard so far. Tracey, just your first reflections.
I think I was thinking about something that Sarah said actually about some of the assets that COVID have given us, and one of the things we're looking at Norfolk and Waveney is the fact that for the first time people have been going somewhere in their community because they're well and they want to stay well. And that's a big shift. So I'm talking about the vaccination centres. So instead of only thinking about our health when there's something wrong with it and going out and getting it fixed, and that could be a crisis point or it could be an early symptom, but it is a symptom, we're actually trying to stay well. And so we want to capitalise on that. So we don't want to shut down our vaccination centres. We want to look at how we can broaden them out and what we can use them for. And that might be around smoking cessation, a lot of the public health things we want to do, health checks in general, weight management, children and young people checks, especially looking at the fact now that we're going to be vaccinating the 5 to 12-year-olds. So there are some things coming out of COVID, I think, that are really important that we keep. I think the other thing as well is around the confusion around system and place and specialist commissioning. the NHS shares that confusion as well. So please don't think that there are answers that people know and they're keeping secret. I think what's basically happening at the moment is that the legislation is going through and the NHS is trying to get ahead of it because it's such a big beast that to move everyone from these organisations, close them down, have employment guarantees, it's a massive strategic change process. But you've got to balance that with the fact that the House of Lords is getting upset that any of this change and thinking is happening before the legislation comes out because they feel it's disrespectful because they haven't signed it off yet. So there's a big balancing act, and in the middle of all that, NHS England is trying to put together guidance that in a lot of cases we don't have. So what we do know is that, I mean, at Norfolk and Waveney, we literally last week only agreed with our places. Other systems are probably a bit more ahead on that. But then in terms of place leaders, they have to be in place by March next year. And in terms of devolving budgets, they're saying in the white paper, substantial devolution by 2026. So none of this is going to happen overnight. And also when we talk about specialist commissioning, it's still with NHS England, and that's been delayed a year. So ICSs won't get specialist commissioning until March 2023.
Okay.
So that's where it is.
That's a helpful clarification, I think, for people. Yeah, we still have some journey to travel. I'm just going to hand to my colleague Sarah now to ask what questions she's picked up. I've got a few up my sleeve that I've picked up, but Sarah, I don't want to miss something. Is there something you want to throw in the mix?
Yes, sure. And I think some of this has been covered a little bit by the panelists already, but there's two questions that relate to one another. So a question from Kim, which is, how are you all involving people in communities to help shape the priorities for the ICS, which we've touched on a bit? And then from Helen, so much of this work is adult heavy. I know children and young people get a mention at the strategic level, but are rarely invited to the table to co-design and co-produce services. Remember, they will be in charge when we look for care homes. How do we get their voices heard consistently?
Right, so one generally about, you know, we've talked a lot about the VCSE, and that's obviously music to my ears, but the VCSE isn't exactly the same as people in communities. And how do we ensure that we hear from those people? But then also a question around children and young people. Who wants to take which? I'm wondering, Kaneez, whether have you got experience on working with young people? Because I think about mental health, there's obviously a massive need for that, isn't it?
Yeah, I've actually worked 20 years in a college, in a sixth form in East London. So I am very aware that young people have a lot to contribute, but so do the teachers that work in those institutions, schools, colleges, universities. So the obvious place to start is the anchor institutions, what we call anchor institutions. Colleges, schools, universities, primary schools have parents and families linked to those institutions and teachers, lots of adults. But they also are equipped with safeguarding teams and other experts inside. And they, in the college I worked we had a health and social care cohort, one of our largest. I think you had about 300, 400 students there. We linked them up with our local National Health Service. So I think, where do you find the young people? You'll find them in the institutions, the GPs, the sort of sector. But if you're doing preventative work, then I think these anchor institutions are really powerful in the space, and we must find ways of bringing them into the ICS thinking, because the head teachers are amazing strategists, by the way, and other leaders sitting inside. Some of the teachers are incredible. We've got to reach out, we've got to listen inside these institutions and find the leaders and then bring them in to the integrated care boards and places. They should be, you know, at the beginning I talked about shifting people power and money as what we're doing. Well, young people should be at the table, and so should some of these education institution leaders. They are incredible, but they've got to be brought in, they've got to be encouraged, there's got to be a comfortable, you know, values driven work going on that says actually we are going to reach them out. Wouldn't it be brilliant to have young people's panel involved in this work? And they are incredible when it comes to solutions and creativity. So yeah, I think it's a great question.
Sarah and Tracey, have you got on your patch mechanisms underway to work with education institutions and young people and that? Sarah, do you want to go first?
We do. It's really important to me actually to oh sorry.
No, you go.
It's really important to me to look at children and young people, and I've been doing some early work in this area. But it's also one of the reasons why I want a really obvious, audacious goal. Because actually, if you think about it, if it's obvious that we're trying to extend years of healthy life, then that's projects that schools can do straight away. Schools can start looking at having health and wellbeing panels. We can start encouraging young leaders. They can come forward to us with ideas. So it's not just about giving people permission through boards and committees and positions. Actually, I want to encourage leadership from every part of our community.
Yeah.
So if we make it obvious what we're trying to achieve, get loads of good ideas coming through. Basically, we need to then create the mechanisms for getting those good ideas and making them happen. And I hope we can do that at place level.
Excellent. And Sarah, what have you got any thoughts in that space?
Yes, absolutely. We all recognise that there's a danger that the whole agenda gets taken up with elective recovery and what's happening on the acute and emergency pathways, as important as that is, that if we're genuinely going to reflect health inequalities and the wider determinants of health, we should be starting very young, and not just within our schools, actually looking at maternity in the first 5 years of life. So taking it right back to the beginning and what we do in that space. And yes, for most young people, they want to engage with services within their schools, and that's a very natural place to start with our engagement. But I would just say that that's the very early years agenda, the first 1,000 days of life, they say, you know, that's where long term we're going to make the biggest difference. The trouble is that there's so much demand to show rapid changes, and the things you really want to do, you may not see the benefits of that for 10, 20 years. So how do we also keep a focus as ICSs on taking a long view and also coming back to mental health issues? Everyone here will be aware of the extraordinary increase in anxiety and mental health challenges for young people over the course of COVID, and we cannot allow that to just be completely eclipsed by a focus on elective recovery.
Hannah, I'll come to you in a second. I just want to mop up a few questions and then pass one of those to you. Sarah, I saw one on, Sarah Sweeney, I saw one on culture change and getting staff empowered to actually work differently with communities. Have you spotted other questions I should ask the panel?
Yes, there's one question here around family carers and how family carers can be supported to lead in co-commissioning as expert system navigators and providers of 90% of adult social care. Is one of the questions. And there's also a question that's come in from RD around how will the ICS and its agenda within the community support staff to break away from hierarchical issues?
Yeah, so Tracey, I'll ask you the question about carers because I know that that's the question that's close to your heart from loads of work you've done in the past. But Hannah, this question, you've already touched on that it kind of leads to culture change, doesn't it? People, NHS staff working differently with people who use services, and people experience that often as very energizing and motivating. I sometimes think system leaders are worried, you know, staff are so overwhelmed, there's too much to do, we can't ask them to do another thing and engage differently with people. But actually, engaging differently with people is the thing that gets you back to the mission as to why you wanted to be a nurse in the first place. And it's really, it frees you from some of the burnout that comes from engaging too much with the lack of humanity sometimes of the system. But Hannah, how do you make that happen? How do you achieve that culture change in practice, or have you seen examples of it?
Yeah, I mean, the best people to ask would be our nurses who are doing it day in, day out, you know. But I think if I would be able to talk on behalf of them, which I wouldn't want to do too often, but if I could say, having, you know, conversations with one of the nurses recently on one of the projects that we worked at, it was that bit about, you know, how do we look at service design so they can get back to doing what they kind of need to be able to do. And it's this idea that somebody's like, right, I have to make 6 calls to a number of patients to do a stoma review, let's say, and they kind of go, I just can't, I haven't got time to make the call. And then actually I was talking to somebody and they said, yeah, but if you make that one call and you're able in terms of to spend that time with them to do, whether it's a review of product or check in how they are, that essentially could prevent something worse further down the line. And it's that understanding, I suppose, of how getting them back to the other bits that they should be doing. But I mean, I'm not qualified to speak on the subject on it, but I just know, having spoken to some of the nurses, that was a recent reflection that one of them had in terms of that. And as I said, that idea of challenging the status quo in terms of, you know, stoma care specifically is what we've been doing. And it seems a bit scary at first. Yeah. I think, you know, the numbers show that it's working.
Yeah. I'm sure Kaneez would have something to add, but I also want to get to the point on carers. Now, one of the kind of, you know, Sarah was mentioning the Christmas tree bill that people hang stuff on, but one of the little successes our sector has had is that they have strengthened the rights of carers to be at the table and be involved in decision making, which is, you know, long overdue and very welcome. And again, it's a small national charity who've done very, very thoughtful influencing. But Tracey, how do you see that panning out in practice? Is the system now more ready to say, what about the carer, or is this still very much an afterthought?
So 2 conversations I've had in the last 24 hours, actually. First was a roundtable this morning with GPs talking about carers, very NHS term, being part of the multidisciplinary team. So basically carers and the person who is ill having an equal voice in care and decisions as the clinicians, as social care. And at the moment it's not happening, and we recognise it's not happening. So we're starting those conversations both locally and nationally about how we can do that. And I think that there's a recognition from GPs that they want to, but there's this weird culture feeling of risk, because if you do something differently to how you do it today, there's a perception that doing it the same way is less risky than doing it in a different way. So we understand some of the barriers and we're starting to work around that. The other conversation I had was with Health Watch, because I want to find our invisible carers. These are carers who are letting their own health, no fault of their own, be impacted because of the caring responsibilities. And we don't notice that there's anything wrong with them until they fall and they have a health crisis before the person that they're propping up and supporting. So looking at how we can support and find invisible carers and work with families and give them what they need, as well as making sure that carers and patients and service users are absolutely have the same level of decision making as anybody from health and social care.
Wow, so it's 1:45. I think I'm going to ask everybody on the panel to have a wee think. If you could just give one piece of advice to a VCSE organisation, either on your patch or, you know, nationally, to get in on this agenda and to make a difference, what would it be? Keep it nice and concise. And given the majority of people on this call are running or working for voluntary and community sector organisations, I think that's quite an appropriate focus for us to conclude with. If you could just give one piece of advice on how to get in on this agenda and make it work for the people you support, what would it be? And I'll ask this question of the panelists. And I will just use the opportunity, whilst you frantically think about what you're going to say, for us to wrap up, to say thank you to everybody who came today. I know you're all really busy. I know Sajid Jarvi gave a speech at the same time. We're very honoured that he came to us. And I know you're all very busy. And I know that this agenda can feel overly technical and very removed from the benefits you try to achieve for the people that you support. And I think rather than me telling you that you need to be educated on the value of this agenda, I would actually say hang on to that feeling. Hang on to that feeling that a conversation that circles around who sits on which board and where is there a dotted line of accountability between which committee and what committee is a long way removed from the benefits you're trying to achieve for people. And take that challenge to the conversations you're having and keep saying, what about people? What are we going to do differently for people? We've just spent 45 minutes. I mean, I sit in endless meetings where I say that. We just spent 45 minutes talking about who should sit on which board. When are we going to talk about how things are going to be different for someone who looks after someone who's dying, or for a young person who's struggling with their mental health, who's dropped out of school? When are we going to have that conversation? So I would just encourage you to hang on to that insight that the structural solution isn't going to deliver on its own, and take that into some of the conversations you have with system leaders, because you are part of the solution, and the way you work will need to be mainstreamed much more effectively. Right, that was my little sermon. But where have you all got to? I'll do it in the reverse order this time. Tracey, you start. What would you say to VCSE organisations on this call and beyond?
If you see something that can be done, come to us with a solution that's costed. Don't assume that I already know what you can do and I've dismissed it, because we probably don't. So think like a commissioner, think about the problems that you've got in your system. We don't have to have competition anymore. It's great. So let's take advantage of that. Come to us with ideas, please.
Wonderful. That sounds like an open door. Hope other CEOs approach this similarly. Hannah, what would you say to, you work with charities and your pathways, but also you said you are a trustee of a charity. What would you say to charities they need to do in order to get in on this agenda?
I'd say keep close to the bill. If there's something in there that you're not happy with, Sarah and others are open to receiving comments on bills, etc., and amendments. And if what comes out the other end of it you don't like, I'd say work with your members to challenge some of it in terms of anything. So with any kind of bill, I'd say. But in terms of, the last message would just be, I just think that talking to each other in terms of across services is going to be key, and the ICSs need to continue to allow that to happen.
Excellent. Kaneez?
I'd say organise a group of people to come together and, share your stories and come up with a plan, and have those conversations vertically and horizontally, start building relationships left, above, up and down. And power is the ability to act, so we must act.
Wow, profound, thank you. Sarah?
Thank you. Well, all of the above, but my message would be amplify your voice. If your ICS doesn't have a VCSE assembly, challenge them and say why, because it's the most fantastic forum. We've got over 250 VCSEs coming together in Devon, and together they're a powerful force and have huge influence. So that's a really, I think, would be my key message here to add to what others have said.
Wonderful. That's a really powerful note to finish on. Obviously, music to my ear. Running an infrastructure organisation in the third sector, do engage with your infrastructure bodies. I think we've got a colleague from NAVCA here. They're very busy supporting in places, building VCSE alliances in systems and places, really valuable work. We are obviously trying to do the similar thing at a national level. And through working with your infrastructure organisations, you can, as Sarah said, amplify your voices and the voices of the people who rely on you. Happy International Women's Day. Do something nice for a woman in your life tonight, and have a good rest of your day. Thank you for leaning in. Thank you for all your questions and comments. We will catch up with the chat later. We can't keep up with it sometimes. And have a good rest of your day, and see you all soon. Thank you. Bye-bye.
Thank you.